The back, pelvis, and hip joints play an important role in the ability to stand upright and walk. The muscles of the pelvic rotator cuff are essential in dynamic stability and mid-range rotation within this complex of joints for normal walking and standing balance. The ability to stand and balance is an amazing accomplishment. Standing is the first test in the ability to walk. Quiet standing occurs when the upper body center of gravity aligns over the lower body center of gravity. In reality, quiet standing is slow, continual arcs of body weight shift over a stable 2-foot stance. The pelvic rotator cuff rhythmically oscillates the pelvis and femur through small degrees of reciprocal rotation. When the pelvis rotates clockwise, the femur rotates counterclockwise. Then the pattern reverses. Through the action of alternating mid-range pelvic and femur rotation, the pelvic rotator cuff provides essential stability and force transfer from the upper body through the pelvic hip connector to the lower body. This postural sway is movement of the pelvis around the ankles via the hip joints and femurs. Because of the ball and socket shape of the joints of the pelvis and hip, this postural sway has a significant rotational component. Since rotation is an integral part of postural sway, the PRC, with its short arc rotation motions, is essential in maintaining standing balance over the foot base of support in a sinusoidal figure-of-8 pattern. The human body is built to move forward. Forward movement depends on continually losing one's balance and catching it. The stance leg performs constantly opposing adjustments with the pelvis to allow the swing leg to move forward through space and the upper body to remain over a base of support while achieving efficient forward movement. Dynamic instability occurs throughout gait. The midpoint of walking is the only momentarily stable time when both feet are on the ground. Otherwise, movement transfers from behind to ahead of the supporting 1-foot stance in a continual rolling motion with pivots at the heel and forefoot. Walking is rotation in a transverse plane through the pelvis, hip, knee, ankle, and foot. Mid-range rotation occurs in the pelvis and femur around the hip in clockwise and counterclockwise movements. The pelvis and femur always rotate in opposite directions at any given moment, and mid-range rotation occurs at the ankle and foot. At heel strike of the right foot, the pelvis is forward in counterclockwise horizontal rotation and posterior tilt in relation to the stance leg, while the femur moves in an external clockwise rotation toward mid-stance. From mid-stance to push-off, weight is transferred from the lateral border of the foot towards the metatarsal heads and the big toe by internal counterclockwise rotation of the leg. At the same time, the pelvis rotates clockwise to bring the weight over the big toe in preparation for push-off. Upon push-off, the pelvis rotates counterclockwise to propel the body forward. In combination with the stance leg, horizontal rotation provides efficient forward progression of the swing leg. At toe push-off, as the right swing leg is rotating clockwise, the pelvis rotates counterclockwise. From mid-swing to heel strike, the femur shifts to internal counterclockwise rotation, and the pelvis rotates in a clockwise fashion. Upon heel strike, the femur again shifts to external, clockwise rotation, and the cycle begins anew. The femur rotation is transferred to the foot as well, which pivots twice throughout the walk cycle in a sinusoidal curve. At right heel strike, a clockwise pivot occurs to transfer weight from the heel along the lateral border of the foot to the midfoot. Between weight acceptance and toe-off, the right foot pivots counterclockwise as it transfers the body weight forward and medially toward the metatarsal heads and big toe. After toe-off, the right foot pivots clockwise as it pushes off through the big toe to swing phase. The pelvic rotator cuff is the primary muscle system controlling the opposing mid-range rotations between the pelvis and femur during walking. This rotation in the transverse plane improves the efficiency and effectiveness of movements in the coronal and sagittal planes during ambulation. The increased efficiency is also due to the fact that rotation in the transverse plane lengthens the swing limb for increased step length, narrows the base of support and the distance between the hips, minimizes vertical rise during push-off, and minimizes lateral shift while facilitating load acceptance over the stance leg. Since pelvic and hip rotation direct ankle and foot pivots as weight is transferred from heel to toe, any limitation or dysfunction in the pelvic rotator cuff changes the walking pattern. There are many walking pattern deviations that occur to compensate when there is pelvic rotator cuff dysfunction. The shuffle walk and bounce step are two such deviations. The shuffle walk is often seen in the elderly. There is a lack of adequate mid-range rotation in the pelvis. The pelvis remains relatively rigid, which decreases step length. The lack of pelvic rotation leads to extremely reduced foot pivots and force transfer from heel to big toe. Without PRC control, walking is inefficient and the risk of falling is significant. Bladder and bowel control is lost at the same time due to dysfunction in the pelvic muscle support of the internal organs. The bounce step is seen in the younger population when there is dysfunction in the pelvic rotator cuff. To compensate for the lack of pelvic rotation and improper foot pivot, there is increased vertical rise during each step. The bounce is the fast transfer of force to the forefoot with little time taken for the heel pivot during stance phase. The step length is shorter and the vertical rise greater. Dysfunction in the pelvic rotator cuff during standing and walking leads to poor balance, increased incidence of falls, and walking deviations that increase energy expenditure and stress on all lower extremity and pelvic joint structures. If these gait deviations are observed, pelvic rotator cuff assessment and treatment is advised.